Hello friends, today's topic is ventilator associated pneumonia. So ventilator associated pneumonia is defined as pneumonia that occurs 48 to 72 hours or thereafter following endotracheal intubation, and it is characterized by the presence of new or progressive infiltrate, signs of systemic infections like fever, altered white blood cell count, changes in the sputum characteristic, and detection of positive agents. So risk for the VAP is greatest during first 5 days of mechanical ventilation, with mean duration between intubation and development of the VAP being 3.3 days. Early onset VAP is defined as a pneumonia that occurs within 4 days and is usually attributed to the antibiotic sensitive pathogen. Late onset VAP is more likely caused because of the multi-drug resistance bacteria, and it emerges after 4 days of intubation. Now, pathogenesis of the VAP, it is the complex interplay between the endotracheal tube, presence of risk factor, virulence of invading bacteria, and the host immunity that largely determine the development of the VAP. So what happens when the endotracheal tube is in situ? So because of this endotracheal tube, there is a loss of cuff reflex and glottic reflex, which causes the accumulation of the secretions, and this secretion will lead into the microaspiration, which are reaching to the lower respiratory tract. So because of this, the infectious bacteria, they will obtain direct access to the lower respiratory tract via microaspiration. Then sometimes the biofilm is forming in the endotracheal tube, which is loaded with the bacteria. Then because of the cuff, then around the cuff, because of the loss of this cuff reflex and glottic reflex, there is a pulling and the trickling of the secretions. And because of this presence of the tube, the another factor which is responsible for VAP is the impairment of the mucociliary clearance of secretion, which causes gravity-dependent mucus flow within the airways. So because of this, pathogenic material is collecting around the anatomical structure such as stomach, sinuses, nasopharynx, and oropharynx, which is causing the replacement of the normal flora by more virulent organism. And because of the continuous positive pressure of the ventilation, there is a forward thrust into this bacterium enriched material, which which again pushes this infected material into the lower respiratory tract. So whenever there is a reintubation following extubation, uh, then this leads to the increased chances of the VAP, and the use of the NIV has been associated with the significant lower incidence of the VAP. So other than this, the host factors is also responsible for the severity of underlying illness. As we can see if the patient is in ICU, most of the patients are critically ill, which is add-on factor for the development of the VAP. So microbiology. So as I mentioned earlier, this early onset VAP is caused because of the antibiotic sensitive organism like Streptococcus pneumoniae, Haemophilus influenzae, methicillin sensitive Staphylococcus aureus, antibiotic sensitive enteric gram negative bacilli, E. coli, Klebsiella pneumoniae, Enterobacter species, Proteus species, and Serratia marcescens. And the late onset VAP is occurs because of the typically MDR bacteria like MRSA, Acinetobacter, Pseudomonas aeruginosa, and extended spectrum beta lactamase producing bacteria. So how to diagnose this one? So we can diagnose this ventilator associated pneumonia on the basis of clinical, physiological factor, microbiological, and radiological factor. So there is one score which we are using, which we can use for the diagnosis of the VAP, and the name of that score is Clinical Pulmonary Infection Score. This score ranges between the 0 to 12, and if the score is more than or equal to 6, then it is showing good correlation with the presence of the VAP. So these are the components of this score, which includes temperature, leukocytes, tracheal secretion, radiographic findings, culture results, and oxygen status. So if the patient is on the ventilator and if on one day, if patient develops fever, if there is rise in leukocyte count, Then we need to see the secretions, whether they are nature of the secretion, whether it is purulent or not. And if the secretions are purulent, then we need to check the chest X-ray finding, whether the bilateral infiltration is present or not, or whether there is any increase in oxygen requirement of the patient is there or not, whether PF ratio is altered or not. So if all these factors are present, then it is most likely VAP, and then we need to send it for the culture. Once the culture is positive, it is definitive VAP. So these various events are divided into three tiers, like ventilator associated condition, infection related ventilator associated complication, and possible VAP. So what is this ventilator associated events and ventilator associated condition? So this include any rise in PEEP for more than 2 centimeter of water, which sustain for the more than 2 calendar days, or rise in FR2 requirement of more than 20 points sustained for more than 2 days after more than 2 days of stable or decreasing daily minimum FR2 level. So if this is associated with the infectious parameter like the presence of fever, like rise in WBC count, one or more new antibiotic starts that continue for more than or equal to 4 days, and all begin within the 2 days before and 2 days after the vac onset. And if it is associated with combination of infection, and if it is with the and along with this, if we have the definitive microbiological result, then we can label it as ventilator associated pneumonia. And if it is without microbiological result, then it is only infection related ventilator associated conditions. So now all this is the clinical parameter. So now the next is bronchial strategies for the diagnosis. So how to diagnose it? So we can diagnose it by the endotracheal aspirate, by collecting bronchoalveolar lavage, mini ball, and the protected specimen brush. So this for the bronchoalveolar lavage requires the bronchoscopic guidance. Minibal is the blind procedure, and for the protected specimen brush, it utilizes the brush at the tip of the catheter, which we are rubbing against the bronchial wall. So according to the IDSA guideline, the use of bronchoscopic bacteriological strategy has been shown to reduce 14-day mortality when compared to the clinical strategy. Now there is a difference in the colony colony forming unit when we are collecting ball specimen and protected specimen brush. So it is more than 10 raised to 3 colony forming unit for protected specimen brushing, and more 10 raised to 4 colony forming unit for ball. So once the specimen is obtained, we need to send it for the gram stain culture and sensitivity. So if the nature of the secretion is purulent, and if we find it when we will say it is purulent, if there is more than or equal to 25 neutrophils or less than 10 squamous cell, then the nature is mostly purulent, and the further we can report it as semi-quantitative or the correlative. Semi-quantitative, semi-quantitative, we can say the specimen is semi-quantitative when the agar growth is moderate or heavy, and quantitative positivity is based on the colony count units. When it is more than 10 raised to 5, we will label it as quantitative. Then we will call the specimen as quantitatively positive. Now, the exact nature of the pathogen and the sensitivity will further take few days and will give us valuable information. Now, the role of chest X-ray. So, as we have seen, the presence of the infiltration is one of the diagnostic criteria for the VAP. But there are many conditions which we are encountering in the mechanically ventilated patient, which will cause this bilateral infiltration, like aspiration, chemical pneumonitis, atelectasis. If the patient is a heart failure, then the chest ray will show the bilateral infiltration. If the patient is in ARDS or pleural effusion, intraalveolar hemorrhage, so this condition will often present with the bilateral infiltration. So only reliance on the chest radiography for the diagnosis of the VAP is not advisable. So there is poor correlation between the radiological sign and the histopathological diagnosis of the VAP. So on flip side, if the negative predictive value of this infiltrate is high. So if there is a absence of new infiltrate on the plain radiograph, then there is a low likelihood of the ventilator associated pneumonia. Now the next is how should we rely on the PCT level? So for diagnosis and for starting the antibiotic, PCT is not useful, but the baseline PCT we should obtain because it will help in de-escalation of the antibiotics. Now, what is the treatment of the VAP? So, for early onset VAP, we can use the third generation cephalosporin like ceftriaxone 2 gram daily, cefuroxime 1.5 gram every 8 hourly, cefotaxime 2 gram every 8 hourly, or we can use fluoroquinolones like levofloxacin 750 mg daily, moxifloxacin 400 mg daily. Or we can use ampicillin sulbactam combination, that is 3 gram every 8 hourly, or artaprename 1 gram daily. So late onset VAP is, as I already mentioned, it is if it is if the VAP is developing after 4 days, along with the risk factor for the MDR. So it is not like if the VAP is developed on the third day, then we should treat it with the then the most likely cause is the antibiotic sensitive, and if the VAP is developed on the fifth day, then the most likely cause is MDR. So we should think about the risk factor for the MDR, and then we should take the decision of starting antibiotics. So what are the risk factor for the MDR? So risk factor for the MDR is age more than 60 years, duration of the mechanical ventilation more than or equal to 7 days, prior antibiotic use, presence of sepsis, septic shock at the time of VAP, then ARDS preceding VAP, if the patient is on any renal replacement therapy or systemic corticosteroid use, and if there is a high prevalence of MDR organism in hospital setting. Then for late, then once it is diagnosed, then how to treat this late onset VAP. So if the patient is diagnosed with the VAP who are at a risk of MDR pathogen and who are in the ICU with a high prevalence of MRSA, that is more than 15%, and resistant gram-negative organism, that is more than 10%, an agent active against MRSA, and at least two antibiotic coverage against the gram-negative organism, including Pseudomonas, is recommended. And if the patient is not in the high risk of the MDR, but we are working in ICU where resistance gram negative prevalence of the resistance gram negative organism is more, then also we need to add the two agents that are active against the gram negative organism, including Pseudomonas. So for MRSA coverage, we can use the agents like linezolid, vancomycin, and teicoplanin. So if there is a high prevalence of the carbapenem resistance organism, then we can use for the empirical combination therapy, we can use polymyxin, colistin. If this in means most in case of the VAP, we are isolating MDR from the respiratory secretions. And from the respiratory secretion, the Acinetobacter prevalence is high, so we can use the tetracyclines like minocycline and tigecycline. If you are thinking about Pseudomonas, then we can use Aztreonam. Nebulized antibiotic has no role, and in country like India, where there is a prevalence of the tuberculosis high, avoid the combination with fluoroquinolones and aminoglycosides. Now, for when to give coverage for anaerobic and atypical organism. So when there is a risk of the anaerobic organisms are present, like reduced consciousness and aspiration pneumonia, then add anaerobic coverage if we are not using meropenem and piptas. And the risk factor for VAP due to atypical organism is Legionella. Like Legionella is colonization in water supply, prolonged use of corticosteroid, cytotoxic chemotherapy, elderly, chronic renal failure, and prior antibiotic use. For atypical coverage, we can use fluoroquinolones and macrolides. Again, macrolides are preferred than the fluoroquinolones. Then, how to prevent this VAP? So these prevention statements are based on the SHIA guidelines. So the first statement is to avoid intubation and reintubation if possible. So what they're saying is whenever possible, manage the patient on the high flow nasal oxygenation on NIV whenever it is safe and feasible. Obviously, when there is an indication of intubation, we have to intubate. Then the next statement is the use minimal sedation whenever possible. That is the benzodiazepine use should be minimal. So whenever the patient is restless, then reflexly we are giving benzodiazepine in ICU. So instead of benzodiazepine, use analgesics or we can give the proper counseling to the patient. So we can prevent the VAP. Then there should be the proper protocol to minimize sedation, and we should follow proper ventilator liberation protocols. Then maintain and improve physical conditioning, provide early exercise and mobilization, elevate the head end of the VAP. So by elevating the end of the bed, we cannot reduce the mortality or ICU length of the stay. But yes, it has a definitive impact in reducing the ventilator associated pneumonia. Then provide oral care with toothbrushing but without chlorhexidine. So good oral care with toothbrushing has uh, it has shown that it can reduce the ventilator associated pneumonia, but the use of chlorhexidine has no uh, uh, but the use of chlorhexidine won't reduce the incidence of the VAP, but it is associated with the mortality. Then provide the daily oral care with but yeah and this statement has the moderate evidence. Provide early enteral rather than the parenteral nutrition. If we provide the early enteral nutrition, then it will help in reducing the incidence of the VAP. Maintain the ventilator circuit. That is, change the circuit only if it is visibly soiled or malfunction. If we frequently change in the fear of the VAP, it won't has any impact in reducing the incidence of the VAP. Then what are the additional approach for prevention of the VAP in adult patient? So what they're saying is if you are working in ICU where there is a low prevalence of antibiotic resistant organism. So how to identify if our ICU is low prevalence of antibiotic resistance organism? So they are saying if the incidence of the ESBL, bloodstream infection in ESBL, if it is less than 5%, then we can label our ICU as a low prevalence of antibiotic resistance. And in that, we can consider use of selective decontamination of the oropharynx and digestive tract, because the selective decontamination of the oropharynx has impact in reduction of the mortality by 13%, and selective decontamination of the digestive tract has had shown that it will reduce the mortality by 18%. But if we are working in ICU where there is a high prevalence of antibiotic resistant organism, that is more than 5% of the ESBL, then antimicrobial decontamination has no role. Then if we know the patient is going to be intubated for more than 48 to 72 hours, then we can use subglottic secretion drainage to avoid the pooling of secretion. Then always consider so that there won't be any accumulation of the secretion which leads into the microaspiration. Then they said always consider early tracheostomy. So recently, one trackman trial was released in regarding this, whether we should consider early or late. So according to this trial, there is a no benefit in mortality or ICU length of stay. But if we'll consider early tracheostomy, then definitely it will reduce the incidence of the VAP. So the early tracheostomy has a role in reducing incidence of the VAP, but it has a no role in reducing the hospital mortality and ICU length of the stay. Then consider post-pyloric feeding tube placement in patients who are gastric feeding intolerance and at high risk of aspiration. Then approaches that should not be considered as a routine part of the VAP. So as I mentioned earlier, oral care with chlorhexidine, probiotics. Regarding probiotics, if they said this in critically ill patient, if there is a trans-abdominal translocation of this probiotic happen, then it will cause the systemic bacterial and fungal infection. So better to avoid this probiotic. Then ultra-thin polyurethane endotracheal tube cuff has no role. Tapered endotracheal tube cuff, no role. Automated control of endotracheal tube cuff pressure and is also has no beneficial effect. And if it is a frequent endotracheal tube cuff pressure monitoring is also has no effect. Silver coated endotracheal tube has role in reducing mortality, but there is one trial when the large trial was conducted, then this silver coated endotracheal tube has role in reducing non-pathogenic bacteria. So it has no role in preventing VAP. So kinetic bed, which includes continuous lateral rotational therapy and oscillation therapy. So I don't think so this bed has any beneficial effect. Then prone positioning, we can use in other conditions whenever it is indicated like ARDS, but we cannot use it in reducing incidence of the VAP. Regarding other healthcare associated infection, but not VAP. Then approaches that are not recommended for VAP prevention, it's stress ulcer prophylaxis, no role in reduction of the VAP. Then monitoring residual gastric volume, also no role. Early versus late parenteral nutrition. Uh, so whether we'll start the parenteral nutrition early or late, it will not cause any change in the incidence of the VAP. Then close endotracheal suction tube suctioning, it is neither recommended or not discouraged. So if we'll summarize this recommendation, then the first one is avoid intubation whenever possible. Use NIV ventilation for selected population. Then we need to assess the readiness for extubation daily without contraindication. Then take step to minimize unplanned extubation and reintubation. Avoid fluid overload. Provide regular oral care. Elevate the head end of the bed unless medically contraindicated. Change the ventilator circuit only if visibly soiled or malfunction. Prevent condensate from reaching the patient. Use cuff endotracheal tube. Maintain cuff pressure and volume at minimum occlusive setting. Suction oral secretion before each position change. Then additional approaches are interrupt sedation daily. Utilize endotracheal tube with subglottic secretion drainage port if we are expected that this endotracheal tube will be in situ for more than 48 and 72 hours. Always consider early tracheostomy. And the practices which are not recommended is prolonged systemic antibiotic therapy, selective oropharyngeal and digestive decontamination, prophylactic probiotic, oral care with antiseptic like chlorhexidine, stress ulcer prophylaxis, silver coated endotracheal tube, and close or inline suction. So these are the trials which was published in the recently published in the Lancet regarding ventilator associated pneumonia. First is a ProfiVAP trial. So in patient with acute brain injury, if single dose of ceftriaxone decreases the risk of early VAP. Then regard VAP trial, it individualized shortened antibiotic duration guided by clinical response was non-inferior to longer treatment duration in terms of 60-day mortality and pneumonia recurrence and associated with substantially reduced antibiotic use and side. Then amicanthal trial is published in 2023 in NEJM. So according to this trial, among patients who had undergone mechanical ventilation for 3 days, subsequent 3-day course of inhaled amic acid reduced the burden of ventilator-associated pneumonia during 28 days and follow. Thank you for kind attention.